Welcome to the To a Kidney podcast from Advancing Wound Care, an online education platform for clinicians.
You're with Monika and Donna, two advanced practice nurses with decades of experience in hard-to-heal wounds, burrowing into prickly conversations.
Welcome to the To a Kidney podcast. You're with Monika and Donna. This will be Legs 11, number 11.
It will be.
But first of all, I am very jealous because we had this sort of, look, you're frowning. I'm very jealous because we had, I think, this tacit competition about who would see an echidna in the wild first. And you damn well got a selfie. So tell us your story about the damn echidna.
Well, we did have a really good competition going, and I think it's become more serious than I first intended.
Yeah. Well,
absolutely. So I was driving home not very long ago, and it was late in the afternoon, and right in front of my house, and I live out in the middle of nowhere.
Yeah.
There's something out there, but, it may as well be. And there was a gorgeous little echidna scurrying across the road right in front of me, making a beeline for the most unattractive dead tree weed. It is a noxious weed in just off the side of my front, the side of my property that I have wanted gone for years because it's so ugly. And now I love that bush and I don't want it to go because this little echidna lives under there. So I jumped out of my Wound 1 van. For anyone who doesn't know, my number plate, I have a special number plate, custom plate, and it's Wound 1 because it's my work van. And I slammed on the brakes, pulled over right in front and got a video as I went out and chased this little guy up till he got under the bush. He wasn't running away from me. He was. Yeah. But my other experience is I've actually got two. I'm kind of one up on you now, aren't I?
Yeah, two up then.
Two up. So we had some visitors from overseas and because our competition was I should backtrack a little bit. Yeah. Our competition was to get a selfie. Yep, with the echidna. And so I thought I was going to grab a selfie when that little guy jumped out down at the front of my house. But he scurried into the bush before I could nab him. And so we had some guests from overseas, some family, and they were staying with us. And we were doing some touring around, and we happened to walk up a mountain with bush on top of it and go up to the lookout. We were looking at some of the monuments up on top of the lookout, and we heard this rustling just over my shoulder, and there you go. A little echidna was there as well, and he was having a fantastic time, was not fazed by us there, and he stayed there for at least 10 minutes. Usually they do, like the first guy, they run away, but this little chap stayed, and he came up to us, he had a sniff around us, he was busy, trying to burrow and get things. I think it had just rained, so whether that.
How do you know it was something? How do you know it was a male?
No, I'm completely guessing.
Yes,
we do not know at all. You can't.
No, apparently you can't. And it's only when they're in mating season that you can pick the males from the females because there's one female and there's a trail of 20 males behind her. So
it's echidna train. I think it's
well, there you go.
The trail and she picks by the one who stays around the longest.
Oh, there you go. Now,
anyway, that's
topics. No, story. I think that's great. It's a wonderful story. But now, goodness knows when I'll be able to see my first echidna in the wild and get an echidna selfie.
I'll stop looking.
Okay. So today we started talking about topics and tried to work out what we're going to talk about. And one of the things that kept coming up was what makes a good referral to a wound consultant. What things we love about good referrals and what things we don't like. Do you want to start, Donna?
There's a lot of places we could start. I don't really want to start, but I will because I guess I have a referral system, and I've been in a lot of places where we do take referrals across a lot of different sectors, and I've seen everything from the A to the Z of referrals. Now, I guess caveat this whole conversation, yes, it's hugely important and makes such a difference to how the consultation or the whole process transpires. It can be very stressful to put in a referral and very hard to know. But we need to say first off that there'll be differences between sectors, organisations, urgency. A lot of organisations will have templates and criteria. So we are absolutely generalising, and there will be a lot of nuances, of course. Referrals that are eligible, not eligible, etc. So we're not talking about those specifics. We're talking about basic information, probably more clinical information. That said, I'm going to start it right at the very beginning. I've received referrals without a name, without an address, without a wound location. Just, can you go and see this person? Oh, but here's the photo. The quality of the photo maybe is highly questionable. It doesn't yield any, but they're very keen to tell you what dressing to put on. So I'm always in private practice and having worked at tertiary centres and in clinics. For me, I always have a wrestle between the need to make it easy to people or not prohibitive to refer to you, because you can't be setting people up for failure, but also what do you accept? And at what point do you say that referral's not adequate? I can't do my job unless there's a minimum amount of information.
I think we were talking about earlier today. I think the thing that gets my goat is not even my goat. One thing that's a total waste of time, as far as I'm concerned, for everyone who sends a referral is when they send us 20, 30 pages of wound management charts that we just simply don't read, because the information on there is either incomplete or there's dressing information which we generally are not interested in because they're often not evidence-based dressings. And that's a terrible thing to say, but that's what happens out in the clinical reality.
I get that all the time. And have before, but what I will get is the swab that was taken 6 months ago.
Oh, yes. Or you ask for blood results and they're, like it's 2026 now, and you'll get a blood result from June 2022. And that's sometimes when the GP's been asked to send the most recent bloods, and that's what you get. But I suppose the complexity too is, even if we start talking about diagnostics and the diagnostics that we really appreciate on a referral is, again, the most recent bloods done and the most recent diagnostics, x-rays. And people often think that if someone's got a wound, we're not interested in their chest x-ray or the x-ray of the knee, but that all helps us form a holistic picture of what's going on.
Oh, for sure. Even medications, I have to remind people a lot for medications. I mean, yes, you can yield that when you're there, but when that information is already available and, people are embedded in healthcare systems already, often by the time they come to us, we're not the first port of call. We should be able to glean that information, not have to go through everything for the 20th time with the patient, although sometimes you need to cover that off, of course. But for me, it's really important to gather as much as possible, even though I will never not go and see someone. For me, the more information that I have at the start makes the visit much more meaningful if you're limited for time.
But not information on a wound management chart.
Not on a, yes, yeah. Correct.
I hate to say that, but there are a lot of wound management charts out there that really don't give us much information.
Do you ever get the, I could tell you what dressings we've put on, but we've tried everything.
Yeah.
But again, it's also it's not useful to us.
Or there are no wound measurements, nothing that you can track the progression. What word did I say I used the other day?
Survival.
Wound survival. That's it.
Wound survival.
Yeah. So it gives us no indication of wound healing or wound survival.
I often find people don't even know how long the wound's been there. And talking about wound survival, we're saying how long is the wound survived for? A couple of months, I don't know, a couple of years. Not too sure, but the patient knows. So if the patient knows, why don't we know?
And that has a lot to say about wound recurrence, wound remission, because what I'm discovering, particularly with the work that we were doing in the vascular clinic, is that it's all good and well. Someone comes in with a wound that is being poorly drained by the venous system, and they're generally phlebilymphatic wounds. But if you don't intervene in that venous pathology, you're pushing the proverbial uphill, because then they have to have compression all the time. The bottom line is we actually have to send them off to get venous interventions done. So what do I want when someone refers to me? I hope to get an accurate medical summary, and that's a big call.
That is a very big call.
Because often the medical summaries aren't accurate. In a hospital setting, it depends on what craft group has completed the referrals as to what information you get. Any x-rays, any imaging, ultrasounds, bloods, recent bloods, even things like vitamin D now. Vitamin D is becoming a very, very important hormone in wound healing and immunocompromised patients. What else do I want? Biopsy results. Sometimes it's really hard to get those things. In some situations, patients are being charged by GPs just to get blood results that I've requested, which is just unfair.
I have found previously when I've been in the initial workup, when in front of the patient and a family, and you'll say, have you had scans done? Have you had biopsies done? Or all of those diagnostics. Oh, yes, I've had them done, or I think they've had them done. But nobody seems to know where the result is. Like no one's actually, they've been done, but no one's chased them down. That can be really hard to put a finger on when they were done, and it takes a lot of time. But my concern is that when people are referring, that they've not already asked those questions, because if something is there, it should be included. So I find I'm uncovering a lot of those at the first visit. So I can see why it's hard sometimes to get those if they don't know about it. But are people asking those questions initially? Look, something else for me as you were going through those things for you, I would 100% agree. Irrespective of the setting of where I'm seeing someone, it's really important for me to know who are the other team members.
Yeah.
And even if that's been a continence nurse they've seen, it could be 2 years ago, they still likely are following some of those recommendations or have equipment from that. So, yes, I'll certainly ask those questions when I'm there, but it means that by the time you can get to do the assessment, you can have chased up previous reports or just get an idea of where you're heading. So, yes, I want to know, is there an OT, is there a physio? How long has it been since you've had a dietetics review, if at all? Has that been considered?
And what I find that often none of the above has been considered, and that's where we'll often go in, and that's the first thing we do is work, you're right, work at which members of the multidisciplinary team have been involved. And sometimes it's so formulaic. The first thing is OT, physio, dietitian.
Very formulaic.
It becomes, to outsiders, it looks like we're really the experts. We're not. We're just having to say the same thing over and over and over again, especially with pressure injury. And there are many things that nurses can do in terms of prescribing equipment, but they're the first things we need in a referral. You're absolutely right. What other things do you look for in a referral?
My other big one, and if people listen to me on socials, they'll know that I talk about goals a lot and barriers, but there are two things I'm going to mention here. I will talk about realistic goals, but what are you wanting me there for? So what is even the goal of getting me involved?
Yeah.
Because I can go in and without that just, come and assess this wound. Well, firstly, are you wanting a one-off visit or are you wanting more support? Who has initiated this? I mean, look, even consent can be a problem. What are you wanting out of this appointment? Because different situations can want vastly different outcomes. If I know that you're wanting wound healing and I can go in and within 5 minutes identify this is not a healing goal, that's going to make a really big difference to how I approach and handle the patient.
But see, you're bringing up a point there, because how many people say, yes, I want the wound healed, but you're going to heal my wound? They actually abrogate their responsibility for healing. I think goals, that's another topic. Again, I'm going to just park that, but goal setting in wound healing.
It's a huge one. I'll put it this way, I've been to places where they say, well, did you look at the other wound? Like, you never told me about another wound.
Oh, yeah.
Like, I'm really talking foundational stuff.
Yeah.
As well. Like, what's your primary focus? What has driven you to want someone to go in, you know? Look, a lot of the time that's articulated well, but you can't assume anything. And I think the more information, the better. Because let me go back a bit, because when you get in there with the patient, often they can't recall everything.
Yeah, of course not.
So, you know, and it's information overload a lot of times. So who's involved in the allied? What are the goals?
And sometimes the things that we want on a referral, well, I'd like in a utopian world, you often can't get, because there are so many difficulties for clinicians to get them, particularly in a community setting. Like GPs don't communicate really effectively with district nurses don't effectively communicate back, and then there's the allied health team in between. Like, communication pathways still, particularly from acute settings into the community and back in and back, are really poor. So then sometimes you get lost in the patient's journey or their trajectory, and that's really hard. I really want to know, as you were saying before, when did the wound start? What made it worse? And that's the thing that often you've got to really put your wound detective hat on. And often wounds have got worse because of something that happened not just the day before, but either a week or 2 weeks beforehand. You know, either they'd stopped wearing their compression, or they'd had a chest infection, or they had a severe bout of pain, or they decided to do a trip, from a regional environment in the car for a long period of time down to a metro environment. That's what you want to know. And that really is often the reason why the wounds deteriorate in the first place, and the thing that's triggered the referral to you. But time, multiple team members, it gets all lost in that. Yeah. And so often we go in there and try and dig that out. But ideally, that's what I would love. And, often I say to people, if people make a choice to do something, for example, they've got a wound on the plantar surface of their foot, the bottom of their foot, and they decide to wear those cute little shoes just for a little trip down to the theatre, down to metro area, Melbourne. Expect that wound in the next week or two will probably deteriorate. And so it's not something that happened the day before that caused the wound to deteriorate, but something that you did or didn't do 1 or 2 weeks previously.
Yeah, absolutely. I'm hearing you regarding the challenges in non-acute settings to gather a lot of that information, and it's we're saying it's tough for us not having that, but it is tough for the clinicians as well.
Absolutely.
So we do know that, and you have to prioritise where you're going to put your time to gather information. So we absolutely understand it, but I guess in referrals, I would like to know what you haven't been able to get, so that maybe I can chase it. But the other thing that and that's hard to put down if people are filling in a referral form, and usually there's some form of paper referral, that system that exists. But the other thing I want to know that is really probably hard to put on a lot of templates, it doesn't always exist, but what does the key clinician or key group of clinicians who are involved with that referral and patient, what do they actually think? I want to know that they can't write down, is what I'm saying.
Yes.
Because I can get to even the third or fourth visit and I'm still working the person up. Because, yes, I'm prioritising what information do I need to get first, what's my second tier, third level of information, that type of thing. And then there'll be a casual conversation, or it might be that I've met a nurse or happen to be chasing a bit of information, so I'll talk to them on the phone, and they say, yes, look, I'm really glad to speak to you. Other people put in the referral, or I'm just making an example here, right? But did you know that XYZ's happening in the background? Like, well, no, I didn't, because if no one's told me, how would I know? And it's usually something that's really key to do with why the wound's not healing or why it could be there in the first place. Absolutely. Like you said, they've put the little ballet flats on and spent all day walking. But no, I'm not going to, sometimes you don't yield that when we're doing our normal line of questioning. So I want to know if there's things like that we should know that don't fit into a nice little neat template when people are sending off a referral.
Or what about the things, again, that you, even if there was a template, you couldn't put on the referral? Like
Totally.
the company X came through, gave education on their product, and now every single person with every single wound is getting that product put on their wounds.
We're never going to yield that from asking a question.
But you'd love that on a referral, wouldn't that be? I mean, I suppose we'd talk about realistic referrals and then, utopian referrals.
Absolutely, yeah. But look, isn't it good that we can drill down to find that information? But it does take us time. And I guess that really goes to show that when people are often referring to us and they're in a desperate situation, and usually people do wait till desperation point to refer, we would love to get referrals earlier. That's really hard.
Yes, the timing.
But when they're in that state, they're not thinking about those nuances and they want a solution to the problem. Of course they want a solution to the problem. That's why they've called us. But it's not about the dressing. Often a lot of these things don't come down to the dressing. But that's the information, the 50 to 60 to 70, 80% of the information that we're getting in the referrals, like the photocopied wound charts. I also want, here's another one that's hard, it's probably a bit of a barrier, but something I will chase. I want to know how long that wound's been like that. But what did it look like a month ago, 2 months ago? Like, how did this wound evolve? Particularly if it's a pressure injury, what did it look like, or IAD? What did it look like initially? How quickly did it break down? What was the colour of the skin? And again, you can't put that into a neat little template or ticker box type of setup.
And it places too much demands on clinicians.
Oh, it does. But those things we don't take for granted. And I guess it's why when I still have a lot of people in my private practice who we end up keeping on and just see them during flares when something starts to break down or recurs again, is expected to do that. I want to get onto it straight away as soon as there's an initial change, so I can see how that skin injury is evolving in the early stages, because it gives me clues into things like pressure, friction, shear, and moisture. What were those? What is the driving forces that caused that wound? Because I think often a lot of that really nuanced information is in the early stages, and we just see a big ulcer by the time we get to it, and it can be tricky. But yeah, they're all the really tricky things that I would love to know, but it's hard.
I suppose ideally, name, address, primary doctor.
Preferred name.
Preferred name, yep. Primary doctor, where the wound is. If you can tell us what you think has caused it, etiology, great. But sometimes everything's called either a pressure injury or, if we're lucky,
a leg ulcer.
Or a leg ulcer, yes, leg ulcer.
Don't mind people saying we're not sure or unconfirmed.
Yes.
Or suspected.
Yes. So the location, and also if there's more than one wound, where are all the wounds? Because you're right, sometimes you come across some amazing wounds in different parts of the body. It's only when you went and visited them and they said, oh, look, by the way, can you have a look at this wound on my husband? He had a skin cancer taken off the top of his head. Take it off and, you're seeing bone.
Absolutely. And that wasn't the reason why you were sending.
No, exactly.
Or wasn't the wound of focus.
No, it was a sort of foot wound, yes. Pathology, imaging, that's all that I want for the bare bones. And then we go in there and do the detective work.
Yeah, that sounds pretty good to me.
Don't give us 25 pages, as you're right. I forgot the photocopy bit. To actually photocopy.
A black and white wound photo, I have to say, is completely useless.
Yes.
I'm remaining calm.
Yeah.
It is completely useless.
Forgot about that. Also, when you embed the image, you don't send the attachment of the photo, but you embed it in the email.
Yeah.
And then you can't actually expand it or, or zoom in on it to have a good look at the wound as well.
Yeah.
But yes, a black and white photo.
Yeah.
And pages of black and white photos.
Oh, yeah. Yeah. Been there. Absolutely had that. Yep. And
still faxes.
Yeah, I haven't had a fax for a while, but it's a bit like the faxed photo. It also useless.
Yeah.
It tells us a lot about the history taking, and to me that this is not information for the referral, but it does the quality of a referral and that really good information. Sometimes it depends on, okay, they'll give you what the fields are showing. So, they'll give the bare bones that way. So it's not always on the clinician that way. Sometimes the system might not lend itself to that. But sometimes that's a phone call or, where we can find that information. But, if these are the people, I don't want to speak negatively of anyone. I really, really don't. But if we're getting, and I'll give you a story of why I'm saying this, if we're getting a really awful referral, and also when the documentation is really sparse when you get there, it honestly gives me an inkling or a clue as to what some of the problem has been in the wound space for that person. And here's the story as it goes for me. I went to, it was quite a long time ago, I went to see a new assessment. I had received a written referral, and yes, there was some comorbidities and all the generic information on there, and the wound had been there for 2 years in the gaiter area, but it was very close to the medial malleoli, and it presented as mixed. I mean mixed as in everything was mixed in there. It wasn't one or two disease processes, but as part of my physical assessment, I asked the patient if I could, as I was measuring the leg, if I could also have a look at her other leg. I wanted to assess the other foot and compare it to the contralateral side. And she let out a roaring laugh and threw her orthotic leg, her artificial leg, up on the table in front of me. And it was quite loud, and said, yeah, well, good luck trying, because I had an above knee amputation 10 years ago. Now, this was a person who'd been seen by the service for over 12 months. It was not, I went through the history from start to end, and it was not written in the history anywhere. So how can people give us a really good, that's like key, she was an above knee amputee.
Yes.
And that had that had a lot of clues as to where I needed to send this lady next, and what the investigations were, and what the etiology was of the wound, of course. But that really scared me, like, in all seriousness. Yeah. That was, it was a real standout case for me about, you can't assume anything. I would have loved to have known she was an amputee.
And, that's very interesting, because then I think about the referrals we used to get into the vascular clinic, and just running through some data at the moment, and it was amazing how many times, even on medical summaries, it wasn't written that the person had either a minor amputation, but even major amputations.
Really?
Not even written in the medical summary.
There you go.
And so, look, you're right. It's not that it's, well, of course we can be critical of any colleagues, I suppose, but at the same time, you're right, there are a lot of systemic issues. Any other things that we want in a referral? Here's another one. Not so much in the referral, but when we get there, and you touched on it before, what other specialists have they seen? because you go in there, oh, yeah, they actually saw a dermatologist. Oh, they saw a dermatologist. Oh, well, they went down and saw the vascular surgeon. Oh, okay. And then what did the vascular surgeon say? Well, I don't know. And this is the issue around surgeons communicating with GPs and that inherent systemic problem. And that really has to be fixed. And it makes it so hard for clinicians.
Yeah, we're working in silos.
Oh, I know.
Completely working in
I don't
silos.
believe that, we're getting people up to Mars and we've got James Webb, all those telescopes, and not telescopes, but, technology, and we can't even get a specialist to speak to a GP who speaks to then the treating team.
Yeah. Wounds do fall through the cracks like that. Yes, there's bigger issues like that, but, where there's grinds in the system and wounds just seem to fall into all of those because they just get left and until, we walk through the front door or the door and try to piece that all together. Sometimes I never know. It is really hard. Like, yes, all that information. I never know the level of questioning and where I'm going to often go when I get in the house, and it can go to places that I didn't think of. I do have a lot of situations where I've done an assessment with a nurse with me, which is always really useful, and I think assists their professional development as well. But when I'm finished, the nurse will comment, I've been looking after this person for a long time and they never told me that.
Yes.
And so that's why you can't assume that we don't need to know some information because it might lead us down a path.
Yeah.
But
we also, being consultants, have the luxury of time. We've got a lot more time.
We do.
So that I think that's a tough call, I think.
Yeah, it is a tough call.
Because you start developing that therapeutic relationship, sometimes.
But that's why we dig, Mon, isn't it? We're talking about echidnas. That's why we dig. We'll just have a suspicion that there might be something in a particular area and we dig further and we scratch to go down that burrow because there could be some really useful information down there.
As you were talking, I thought about another thing. Oh, yes, this is another thing. Okay, so I suppose it's about identifying what are the biggest risk factors for that person and their wound.
Mm-hmm.
So if, for example, I'm getting a referral for a pressure injury or a person who's got a wound on their foot, one thing I do want to know is whether it probes to bone.
Mm-hmm.
It's such an important thing. For example, if you're going to send me a referral with a wound that probes to bone, don't worry about sending me anything else because, first of all, I'll prioritise. If anything, I'll say get them to hospital. Often it's don't bother referring to me.
Yeah.
Send them to ED, and that can expedite care very quickly. So, it's a shame you don't actually always see that on wound charts, whether a wound probes to bone.
No, I struggle to have seen that.
Yeah, and as a consequence, people often don't even consider probing the wound and really checking the depth of the wound.
Not at all.
But, that's something that I'd like, just thinking about what I'd like on referral. Yeah, I suppose we're mixing between what we want on referral and what do we want when we get there. So let's just break that down because I think we've had a lot of content. So let's go back to what's the bare bones that we need on a referral.
I'm going to add a bare bones one, and it's probably because of the space that I work in. Are there cognitive or communication deficits from the patient and or family?
Yes.
Because we often feel as though, or I do, my hands are behind my back when I do some of this work because I am a sole practitioner as well. So I'll often don't have a nurse with me, and that could be whether it's in aged care or a home setting, and I actually can't tell.
Oh, yeah, without doing further assessment.
Well, I know that there can be a level of cognitive decline or memory loss, and often that's known, but it hasn't been communicated. So how can I gather information in that setting.
Yeah, because you don't have...
Yeah. So, yeah, back to that question. I think that's a key.
Actually, it's not often written, is it?
No, it's not written.
Not even on the medical summaries.
But we do...
Not always, but it gets missed.
Yeah, yeah. So, back to your question, in summarising, the key stuff.
Bare bones. Well, obviously we want demographic information.
Yep.
And again, I still think I want to know who the key medical professional is in that team.
Absolutely.
If that person's got a wound on their feet, I want to know who is their podiatrist.
Mm-hmm.
And in a community setting, I want to know whether that's a podiatrist whose main focus is on foot and nail health rather than high-risk feet.
Yeah.
So that's sort of the bare bones there. And then blood results, any biopsy results. Biopsy results from any time, really. Blood results.
Less time critical.
Blood result, biopsy less time critical, I think, or depends on the circumstance, actually. But blood results, if they've got an infection, if we're questioning whether they've got an infection, I don't want their FBE from 6 months ago. No.
No. 6 months ago isn't useful.
And I don't want a CRP. I don't want their CRP from 6 months ago. Or maybe, but no. So it's more recent bloods. Let's give them what about some guidelines? Well, it depends on the circumstance. You can't really say.
No, I'm chewing it over in my head. That's why I haven't thrown out one. I'm thinking of extremes. It depends what you're looking for. But
yeah,
but then again, for a lot of community people, if 6 months has been the last time they attended the doctor because the GP's not involved in the wound management and they would prefer not to go, or maybe they don't have a regular GP. There's a lot of reasons why someone won't go. That might be the last one that they've got.
Or they go in with inflammatory dermatitis, or could very well be cellulitis, and you ask them, did the doctor run any blood tests? No. What they do, just run antibiotics.
Yeah.
Did you feel hot, fluey?
Unwell, yeah.
Unwell, myalgia, aches and pains? No. The doctor put me on antibiotics. Yes, but I still think pathology, imaging, anything. If you think that even if they've got the wound on the tippiest, most distal point of their foot, it's still important. If they've had a brain CT, it may guide us, as you were talking about, any cognitive impairment or any acquired brain injuries that they've received, or migraines, or terrible headaches that really impair their decision making. So that gives us even an idea of why they've got a wound on their foot. So anything like that.
So I think that's about wound referrals.
Okay, all right.
Wrapped up.
So in summary, I would prefer 40 pages of fuzzy, out of focus, photocopied in the old-fashioned way, almost unintelligible.
Yes.
Image results of imaging, blood results, any testing that person's had, any specialist they've been to, any specialist report that you can actually get your hands on.
Oh, yes, that's gold.
Rather than 40 pages of wound management chart that I never, ever read.
Yep, absolutely. I will read a very long geriatrician report before I won't even look at the wound chart.
Yeah.
They're quite gold. So, yeah, all of those reports are gold.
Yeah. Yep. So hopefully people have got the idea about wound management charts.
For sure. So thanks for listening in to this episode. We're sure that there will be some food for thought in there around referrals, and acknowledging that everyone does have different limitations and different systems to do that in, but spare a thought for the person you're referring to.
Yeah. And everyone knows the context that they work within, and
yes,
it's all good and well for us in our ivory towers, well, not ivory towers, but in our positions to be saying what we'd like. we're not working right in those environments. We're always coming in as the experts to advise. But at the same time, there are many things that we can see that can actually simplify workflow, especially around wound management.
Absolutely. And we don't want to assume that everyone actually does know what we do, because that does happen a lot. It will turn up and they'll say, oh, you're here to do the dressing. Well, actually, no, I'm not here to do the dressing.
No.
I'm here to assess the patient and the wound. So that's why we have covered off on a lot of this referral information. Thanks, Mon, for another great episode.
Thanks, Donna.
We'll see you in the next one.
Okay, bye.
Bye. At Advancing Wound Care, we're proud to stand alongside clinicians who lead with heart, curiosity and a deep commitment to doing right by the people in their care. We are so grateful to have this opportunity to share our learnings and challenges with you. Hopefully this episode has inspired you to keep burrowing down to issues that bug you.
If you liked today's episode, follow and subscribe to the To a Kidney podcast on Spotify, Apple and YouTube. If we were too prickly, we'd also like to know. Reach out to us on our Advancing Wound Care socials, where you'll also find hints, tips and resources. And for more value, join our mailing list on our website for our newsletter and to be the first to hear about online education opportunities.
All our contact details and links we've mentioned are in the show notes below.
We will see you in the next episode, and in the meantime, go forth, be curious and burrow into some ant nests.
There'll be struggles, there'll be